Thank you everybody for joining us. I'm Mary Rojas. I'm the Director of the Medical Student Research Office. Welcome to the oral presentation portion of the 4th Annual Karen Zier Medical Student Research Day. These past 12 months have been very hard for everyone. Last year at this time, our annual event was canceled due to the rapid rise of COVID-19. Nevertheless, the Mount Sinai research community pushed forward. More than ever, research was essential for fighting this devastating disease. Our faculty and medical students found ways to continue doing research, and in some cases, even advance COVID-19 knowledge. Today, in the poster sessions, we heard about research being done from over 100 medical students. And shortly, you will hear from the medical students who were selected to give an oral presentation. This is the program for the remainder of the afternoon. But before we move on to the program, I wanted to first recognize and thank the many people involved in bringing you today's event and the many that have supported and guided the medical students. The event committee members, the abstract book designers, which should be up on the website soon, looks beautiful. The special guests to the breakout rooms, the IRB members from the IRB Grants and Contracts Office and Mount Sinai Innovations Partners. The track advisors who have worked with the medical students in years 1 and 2, helping them prepare for Research Day. The poster facilitators who not a few minutes ago finished facilitating a range of 20 different poster sessions in topics such as COVID, well-being, machine learning, orthopedics, cardiology, a whole range of different topics. The mentors. Sinai students are fortunate. They work with faculty all throughout the entire health system. We don't limit them to certain faculty. They're invited to work with anyone. And so here you have the list of those that work just for Research Day. If we were to explode this out for students who are doing scholar year, other activity, this list would go on and on. So thank you, mentors that have worked with students. And the name of the poster presenters, I know this is the oral portion, but I think it's still nice to sort of show you the list of the students that have done poster presentations. I trust you enjoyed the sessions. Thank you very much. Please join me, even in silence, but like applauding the students and everyone who has made this day and all the research in this past year very possible. Now on with the program. It's my honor to introduce Dr. Dennis Charney, the Anne and Joel Ehrenkrantz Dean for the Icahn School of Medicine at Mount Sinai, President of Academic Affairs at Mount Sinai Health System. Dr. Charney?
Yeah, thank you, Mary. And I'd like to add my thanks and congratulations to everybody you've already mentioned, but I'll acknowledge them again. First, I'd like to acknowledge yourself for the great work that you have done during a year, as everybody knows, that has been unprecedented in terms of the stress that we've all had to deal with, dealing with the pandemic, and we're still fighting. But it's amazing the work that you have done, and Jenny Lynn, Keith Siegel, and the mentors, you know, all the people you have acknowledged. I want to add my thanks. Most of all, I want to acknowledge our students who have demonstrated in so many ways this year, dedication, passion, courage, and now doing great science. And when I looked at the abstracts, I think it's 118 abstracts that, you know, represent literally all areas of biomedical science. It's an incredible accomplishment to have done this during, you know, this year. And it just speaks so well of the kind of students that we have at Mount Sinai and the mentors. And I want to say, as I say many times, the school is 100% committed to fostering research by our students. And literally the checkbook is open. I shouldn't say that, but it is. You know, when it comes to supporting student research, I want the limitation of the research done by our students to be their imagination. So, and you all, leaders, students, mentors, make this possible. And so, thank you very much for the great work that you do.
Very much. Thank you very much. And now I'd like to turn it over to Dr. Muller, David Muller, the Dean of Medical Education at the Icahn School of Medicine. Dr. Muller.
Thank you, Mary. So I'm certainly going to echo everything that Dr. Charney said in terms of expressing my thanks to everyone, and in particular to Mary and her core team, who in the relatively short tenure, Mary, that you've been here, you have built an incredible research enterprise on the strong foundation that Karen Zier left us with. But it has just taken off, and it's, I think, emblematic of your energy and your creativity and also your incredible rigor. So thank you for that. I think Dr. Charney was a little bit tongue-in-cheek about the open checkbook, but I'm going to say that it is 100% true. We have never, ever heard a maybe, certainly not a no when it comes to supporting student scholarship. I mean, it's really been incredible every year to get a more and more expansive body of work that comes from all the resources the school provides. And a lot of that is thanks to Dr. Charney's belief in the work that we do and certainly belief in our students. And in addition to congratulating everyone who submitted and has, is in the book and certainly the oral presenters, I think the pandemic is so much on all of our minds. To have accomplished this in the face of all the challenges we've had is certainly remarkable. And I'm going to say even one step beyond that. I don't think that we would have gotten through the past year if it wasn't for this type of work. We talk a lot in the medical school about, we have this expression MD plus. Like, yeah, you're coming here to get an MD, that's great. You're going to be a great doctor. We're going to make sure of that. What's your plus? And everyone has a little bit of a different plus. For some people, it's global health. It could be lots of things. But I think if this year proved something to all of us, it is that without that plus, you can't make it through the hardest times. Without that ability to express something that you are deeply passionate about, something that you love, that's linked to your core work. Your core work is being a medical student. My core work is being in med ed administration. Everyone has got that body of work. And then there's something that is on outside and on top of that that makes it great to be here, makes it great to be in this profession. And this day, Medical Student Research Day, is so perfectly emblematic of that. It is the inspiration that comes with discovery and really asking critical questions that keeps us, sustains us in the most difficult times of our lives. And so I want to thank everyone, all of our students, and again, Mary and her team, for making it possible for so many of us to have that plus, which has gotten us to this very, very successful point in time where we can thank things like science and vaccines for sort of the light at the end of the tunnel. So just expressing my appreciation to everyone again, and looking forward to hearing all the presentations today.
Great. Thank you so much, David. It's my pleasure to start the introductions for our speakers. Our first speaker is Emma Klein, who is going to be speaking on non-invasive approach to the prediction of severity, degree, and survival in COVID-19 using a combination of semi-quantitative, quantitative CT findings, and plasma cytokine assessment, work that she did with Dr. Tauli in radiology. I would like the audience at this point to please, if you have any questions, put them into the Q&A. We will be monitoring it and we will facilitate those questions at the end of Emma's talk.
You're on mute.
You're on mute. There we go. Thank you so much. So the title of my talk today is The Non-Invasive Approach to the Prediction of Severity, Degree, and Survival in COVID-19 using a combination of semi-quantitative, quantitative CT findings and plasma cytokine assessment. For a little bit of background to start, the treatment options of COVID-19 vary depending on the severity of the disease. Studies have shown that early cytokine assessments are reliable predictors of both severity and survival of COVID-19 patients. Studies have also looked at the potential utility of CT findings in predicting both severity and patient outcome in COVID-19. So the goal of this study was to assess the performance of both visual chest CT assessment as well as quantitative chest CT assessment compared to a cytokine signature for prediction of severity and death in patients with COVID-19. The study design that we used is listed here. Our inclusion criteria was a SARS-CoV-2 PCR positive test, a cytokine assessment, a chest CT scan, and CT and cytokines within 72 hours of each other. We searched for patients in EPIC using the terms viral pneumonia or COVID from the dates of March 1st to May 8th. And after excluding patients based on our criteria, we ended up with a final cohort of 56 patients. The cytokine signature that we used was based off of an assay that was used actually in a study done at Mount Sinai. And we focused on 4 different cytokines: interleukin 6, interleukin 8, TNF alpha, and interleukin 1 beta. For the CT visual score, 2 independent radiologists read the CT scans, and they assessed for the degree of involvement for each of the 5 pulmonary lobes. Involvement refers here to ground glass opacity and consolidations. So for a lobe that had no involvement, it was given a score of 1, and this was all the way up to a score of 4 for severe involvement, which meant that greater than 76% of the lobe was involved. The 5 lobes were then summed to get a total CT score. So on the right, we have an example here where the yellow areas are indicative of the involvement within the lobes. And here, the CT score summed up to get a total of 17 points. For the CT quantitative assessment, we used a program called 3D Slicer with Python. And how this worked was we imported the CT scans into the program, and it segments out the scans based off of Hounsfield unit thresholding. So for the well-aerated lung, that was for a Hounsfield units below -500. Ground glass opacities was the next step up between -500 and -100. And then consolidations was the final step up, which was between -100 and +100. This program gave us 4 CT quantitative characteristics, including total volume, well-aerated lung volume, ground glass opacity volume, and consolidation volume. So here is an example of this assessment. So on the top here, we have 3 examples of CT scans of lungs. And then on the bottom, we have the segmentation that the software performed. So in this reddish brown color, we have the well-aerated lung. So you can see on the bottom left here that this lung is predominantly well-aerated. There is a little bit of ground glass opacity and consolidation in the anterior portion of the right lobe up here. And as we move to the left, there is more and more ground glass opacity and consolidation, particularly in the posterior lobes, as you can see here in the yellow and the green. So the 2 different endpoints that we focused on for this study were severity and death. The severity scale that we used was developed by pulmonologists at Mount Sinai, and it separates patients into 4 distinct categories: mild, moderate, severe, and severe with end organ damage. So we separated patients into these categories. And then, like I said, the second endpoint that we looked at was death. For statistical analyses, we did a univariate analysis of cytokine and CT assessment to evaluate severity, for which we used the moderate disease group compared to the severe disease group, as well as the risk of death. And then we did multivariable analyses to build models in a training set using the cytokines, the CT visual, and the CT quantitative data alone and in combination to predict outcomes. So the results. For the prediction of outcome severity, these were the statistically significant variables that we found between the moderate group and the severe group. Interleukin 6, interleukin 8, the visual score, the well-aerated lung volume, ground glass opacity volume, and the consolidation volume. So then we used these statistically significant variables to create 4 different models: the cytokine, the CT visual model, the quantitative, and the combined. And what we found was that the area under the curve for the combined model was greatest at 95.3. And this functioned at a sensitivity of 86.4 with a specificity of 91.2. We then did the same exact thing essentially for survival. And we found that these were the statistically significant variables. And again, when we created the 4 different models here, we found that the combined one functioned at the greatest area under the curve of 80.4 with a sensitivity of 82.8 and a specificity of 76.5. So a few limitations of this study are that we had a fairly small sample size of 56 patients. And so there were a small number of deaths, and this resulted in the risk of overfitting our curves. And for the quantitative assessments, there's also the risk that we overestimated the ground glass opacity volume as well as the consolidation volume, because there were times when the software included, for example, vascular structures in these volumes. In conclusion, we have shown that radiology findings alone and in combination with cytokines are helpful in predicting COVID-19 patient outcomes. It seems that the combined model had the best performance, and CT quantitative analysis represents an interesting tool to evaluate pneumonia lesions. Future directions for this study would be to include more patients, assess more outcomes such as intubation risk, as well as refine CT quantitative methods combined with deep learning models. I would like to acknowledge all of the collaborators who were a part of this study, including the body MRI group, and especially my mentor, Dr. Bashir Tawuli, the Department of Immunology, as well as the chest radiology section. Thank you. And now I will take any questions.
Yes, we have one question. Do you have an idea why the combined model had higher AUROC when distinguishing between moderate versus severe COVID relative to distinguishing between survival versus mortality?
That's a good question. One of the issues that I brought up when I talked about the limitations is that we possibly overfitted these curves. And so if we look at the combined model for the severity degree, we actually have a greater number of variables in the combined model for this one than we do for the survival one. And so that could be one reason why we ended up with a higher AUC for the severity degree than for the survival one, if that makes sense.
Okay, great. And we have another question. Okay. Did patients undergo CT scan for a research protocol? Yeah, go ahead.
Oh, I was just going to say that no, these patients were scanned as they went into the ED essentially, and then we backtracked. This was a retrospective study, so they were not part of the study when they went in.
Okay, and so they said if not, do you have any information on the indications for obtaining CT chest?
I don't exactly. I believe that a lot of these patients presenting with symptoms of COVID were scanned when they presented to the ED. So that was just, I don't know if it was protocol, but most of them either got an X-ray or got a chest CT.
Okay, great. Yeah, saying especially early in the pandemic, most patients only had CXR and CT. So I wonder if that might have been skewed. That might have skewed your results somewhat towards including patients with more severe disease to begin with. Thanks.
Yeah, I mean, it likely did because as I mentioned, the severity degree, when we compared these patients, we were looking at the moderate group and the severe group. And the reason we did that was because we didn't have patients in the mild group. So this likely did skew more towards patients with severe cases.
Great. And everyone's saying thank you for the great presentation, by the way. And another question, I know you mentioned small sample size as a possible limitation. Would love to hear more about how you split up your data to train versus test your model, or however you split up the data to fit model versus measure its performance.
Yeah, so this is a training set right here. We haven't tested this. So that's why I said that this data may be overfitted, because my point there is that when we actually go to validate this on a test set, it may not function as well. The AUC may not be so high. This seemed to fit this training set really, really well. And that's why the AUC is so high, but on a test set, it may not be so high.
Great. I think there's no more questions. I think we're ready for the next presentation. Jenny, do you want to take over? Yep.
Thank you. And thank you very much, Emma. That was excellent. Our next presenter is Jeffrey Okewunmi, who is going to be speaking about racial disparities in care and outcomes after total hip and knee arthroplasties. Did the comprehensive care for joint replacement program make a difference? Work that he has done in the Department of Orthopedics with his primary mentor, Dr. Josh Van Toren.
Can I get a confirmation that you can see, that you can hear me? You can also see my slides.
We see your slides beautifully.
Yes.
Perfect. All right. So hi, everyone. Thank you for coming to this presentation. I'm Jeffrey Okewunmi. I'm a second-year medical student, and I'm really excited to share my summer research project with you all. Under the Departments of Orthopedics and Population Health, I conducted a research project on racial disparities in outcomes after total hip and knee arthroplasties. A little bit of background about how this came about. I approached Dr. Toren about starting a research project in January of 2020. And when he asked what I was passionate about, I responded to disparities, and we arrived at this project a few months later. I was really excited about this intersection of my two interests then, but then with the events of this past summer, this project became all the more important to me. So the basis of this project relies on two main principles. First, the understanding that racial disparities exist in care. Not only that they exist, but that they also appear differently throughout different stages of care, before, during, and after surgery. And I've highlighted some of the disparities that are discussed in the literature on this slide. I've also added arrows in the center, highlighting that, especially in the context of community health, these experiences are cyclical. The second main basis of this project is the institution of bundled payments. In 2016, the Centers for Medicare and Medicaid Services initiated the Comprehensive Care for Joint Replacement Bundled Payment Model, which I'll refer to as CJR because that's a mouthful, for patients that were undergoing total joint arthroplasties, or TJA, and which includes total hip and knee replacements. This is an example of a transition from volume-based to value-based care. But what's special about this program is that some hospitals were assigned to this mandate while others weren't and were allowed to continue as normal. In the hospitals under the mandate, instead of the traditional fee-for-service model, these healthcare organizations received a single bundled payment for all services related to TJA from the index hospitalization to 90 days after surgery, thus incentivizing healthcare facilities to both reduce costs and improve the quality of care. For procedures that cost less than the bundle, the hospital would keep the excess, and for procedures that cost more, the hospital would be responsible for the difference. This incentivized standardization of care has the potential to influence disparities, but this hasn't been investigated before. And that transitions into the aims of our study. First, we wanted to investigate trends and disparities, and then we wanted to investigate the effect of the CJR program. This is a quick slide on the patients that we included in our study. To frame our study, we looked at elective procedures in Black and white patients. We chose this group for two primary reasons. First, the Medicare enrollment database variable is known to severely undercount certain other ethnicities. And secondly, a plethora of other studies look at Black and white patients to investigate disparities, and we wanted to build on that existing literature. Of note, we had about 1.5 million patients in our cohort, 5% of which were Black, and about a quarter of procedures occurring in CJR hospitals. Using these groups to look at both study aims, disparities were assessed in terms of preoperative characteristics, characteristics during hospitalization, and postoperative characteristics. The specific variables are here on this slide, but I'll discuss this more in the results section. And with this group, we had a set of analyses for each aim. For the first aim, we analyzed trends using descriptive stats. And for the second aim, we used difference and differences analyses to analyze the interaction between the three main variables of interest: before and after CJR implementation, outcomes in CJR and non-CJR hospitals, and race. A gross oversimplification of this analysis is that we analyze the outcomes with regards to race in the different hospital groups before the intervention and after the intervention, and then calculated the differences in these two different time periods, and thus arrived at a difference in differences result. So using these methods, we can now transition into the results. In the next three slides, the graph on the left shows trends over time, with one on this graph indicating that there's no difference in the likelihood of Black patients compared to white patients for the specific outcome, with lines above 1 signaling an increase in likelihoods in Black patients, while lines below 1 increase a decrease in likelihood. And the table on the right shows the result of the difference in differences analysis, looking at the effect of CJR. A positive change in this column indicates an increase in difference between the two groups over time, and a negative number indicates a reduction in disparities. So in our study period, we found that prior to surgery, there were disparities that existed and persisted with no drastic changes over time, as shown in this graph on the left. And we see no significant changes with regards to CJR. Of note is the persistent comorbidity in the dark blue line here on the left. Considering the association between the increased comorbidity, increased complication risk, and increased costs, there was a concern that this policy would create biases in patient selection. But that wasn't seen in our study, which was encouraging to see no lemon dropping or cherry picking. During surgery, trends show that there were disparities that existed and persisted, some of which grew. None of these were clinically significant when applied to the CJR program, but the trend that we see here with the transfusion and length of stay is striking in the unadjusted analyses. We see here that over time, Black patients were more likely to be in the hospital, and while in the hospital, they had more transfusions. And after surgery, we see that disparities exist, persist, and some of which reduce over time. We also see significant changes for the first time with regards to the effect of CJR. Much of this can be attributed to the elements incentivized by the program. With bundled payments, hospitals are incentivized to reduce expenditures across the continuum of care. Other studies show that savings are driven by reduction in post-acute care spending, which can account for up to half of the entire episodic cost. We see here that 90-day readmission, discharge for post-acute care, and outpatient Medicare payments, all of which directly relate to costs, are reduced as a result of this health policy. And starting to wrap up, our study isn't perfect. Our cohort only includes Medicare patients. Ultimately, healthcare should strive to provide equal care regardless of payer, but current studies show that differences in outcomes exist with different insurance payers. Also, the Black patient utilization trend in our studies, it follows the national trend in lower decisions to undergo elective surgery, which can be attributed to a variety of factors, but it is a limitation of our study that the groups are unbalanced. The races that we used, thirdly, the races that we used are the ones that are inputted by the claims database. And I mentioned earlier that this can sometimes be wrong. And so all the patients in our group may not be accurately represented. And lastly, as both a retrospective and observational study, causal inferences in our study can't be determined. So in conclusion, our study demonstrates the encouraging finding that bundled payments have the potential to decrease racial disparities. We found these reductions in 3 main cost drivers, but it's important to recognize that these disparities weren't eliminated, they were only reduced, so there's still work to be done. A strength of this paper is that it shows the response of care processes to the incentives created by the CJR program. With this in mind, we understand that designing future policies, we can target specific areas of care to improve. Before we do that, however, we have to first acknowledge that there's work to be done and then do more research so that we can carefully craft and create any policies. And I'd be remiss if I end this presentation without thanking the CMCA for funding me this summer and for Dr. Palermo for taking time out of her busy schedule to talk to me and give me guidance on different things to consider when doing a project like this. I'd also like to thank the MSRO for their guidance in this process, and also the research team with Dr. Poran, Vivian, Meredith, and Dr. Muha for their support of me with this project. And so with that, thank you for listening, and I'll now take any questions.
Great presentation, Jeffrey. So yes, we have a couple of questions for you. This is super interesting. What's the current status of this project? Have you shared this project anywhere else? There seems to be a lot of interest in bundled payments and disparities in outcomes as well.
Yeah, thank you. So with regard to this paper, we are currently drafting a manuscript to submit to a journal, which I'm excited about. And in November, we submitted this project to the American Association of Hip and Knee Surgeons. And we were selected to present our abstract there, and we were actually recognized as a top 100 poster at that conference.
Awesome, great. And then we have another question for you. Great presentation, Jeffrey. I'm curious about your methodology. When you were looking at the effect of CJR, how did you make your cutoff?
Yeah, so I didn't actually mention that in this presentation, but so the CJR was instituted on April 1st of 2016. And so we included a washout period of 6 months before and after in our second aim. So in that period, we allowed 6 months for hospitals to get adjusted, to pre-get adjusted and after get adjusted. And so then used the time period outside of that to do our analyses.
Awesome, great. Great, and again, fantastic presentation. Thank you.
Cool, thank you so much.
Well, Jenny?
Wonderful. Thank you so much, Jeffrey. Our next presenter is Kevin Weiss, who will be speaking on dynamics of anal and cervical HPV in women with HIV, relationship to anal precancers, work that he's done with his mentor, Dr. Keith Siegel.
Great, I'm just pulling this up, but are you all able to hear me well?
Yes.
Yes.
Great. So So my name is Kevin Weiss, and I'm going to talk to you a little bit today about anal and cervical HPV infection in women living with HIV and how there might be a relationship with the development of anal precancer. So as background, squamous cell carcinoma of the anus has an incidence that's rising in the US, particularly among women. Squamous cell carcinoma is responsible for more than 90% of all anal cancers, and more than 90% of all squamous cell cancers of the anus are attributable to HPV infection. So we now know that anal cancer is, again, rising in the US, and it's now predominantly a disease of women, particularly women living with HIV, where it's the second most common solid tumor. We also know that women living with HIV are highly susceptible to human papillomavirus, or HPV, associated precancer and cancer in both the cervix and the lower anogenital tract. And the reasons for this are probably multifactorial, but one of the strongest contributors that we're aware of is the fact that HIV causes immune dysfunction, which can lead to the persistence of the HPV virus in these anatomic regions. And then finally, we understand some of the dynamics of HPV infection at the anal and cervical sites, but the relationship of those with anal cancer precursors, which we'll call H-cells or high-grade squamous intraepithelial lesions, are not well understood. And there's some persistent theories in the literature about the fact that the cervix may be serving as a reservoir for HPV infection at multiple sites. So to briefly talk about the natural history of HPV in anal cancer. So most people will start with benign squamous epithelium in the lower anogenital tract, which is represented on the left side of this diagram. Most people who do get infected with HPV will not progress to anal cancer, but we can see a progression to various stages, including a low-grade lesion or L cell, low grade, an H cell or high grade, and some people do eventually progress to anal carcinoma. And the idea behind anal cancer screening is that we want to capture people at the H cell stage or perhaps even before, treat them to prevent the progression of H cell to anal cancer. And we're primarily interested in two particular HPV types that we consider higher risk for the development of cancer. Those are HPV 16 and 18. So to briefly share what the current screening and referral guidelines are, there's a lot of information on this slide, which is from the New York State Department of Health, but I just want you to focus on the bold text. So clinicians are encouraged to inquire annually about anal symptoms that their patients are experiencing, inspect and perform exams, but the information about anal cancer screening is really given as a shared decision-making, and that can include tests such as anal cytology or anal pap smear, which is equivalent to a cervical pap smear that women undergo. And then for people that do receive cytology, have abnormal results, they're referred for what's called high resolution anoscopy, HRA, which is equivalent to a colposcopy in women. So from this, you'll see that the information, one about anal cancer screening, but also about HPV testing, is given this way, and this leads to heterogeneous implementation of screening procedures. So some women are screened, some women are not. And more recently at Mount Sinai, there's been some really interesting work surrounding the potential role of HPV testing and screening. So in a cohort of people living with HIV and people who had engaged in receptive anal intercourse, high-risk HPV testing alone at the anal site was associated with a 92% negative predictive value for precancer. And negative predictive value does vary with the prevalence in the population, but we feel that that's similar to the cohort I'll be describing shortly. And then even more recently, in a cohort of women living with HIV, high-risk HPV testing alone, or the combination of HPV testing and an anal pap smear, had very high sensitivity in detecting anal precancer or cancer, but low specificity. So one of the questions that really came up is, could anal HPV testing serve as either a risk stratification tool or a screening tool? It has many of the characteristics we desire in a screening test in terms of having very high sensitivity. So we sought out to compare the prevalence of HPV infection in the anus to other genital sites for a group of women living with HIV, and to assess the contribution of persistent anal and cervical infection to the development of anal H cell or anal precancer. So this slide describes the methods. So the diagram at the top shows some of the key time points for the study, as well as some of the key lab tests and measures that we were interested in. But in brief, we had access to data from a large anal cancer screening cohort at the Mount Sinai Health System, typically about 7,000 women. We screened about 1,000 charts using a retrospective chart review. So that's inclusive of notes from the pathologist, biopsy findings, as well as the clinician notes. And we identified 144 cisgender women living with HIV as part of this pilot program. So all of them were screened between 2012 and 2019. And each of them had undergone anal HPV DNA testing, cervical HPV DNA testing within 6 months, as well as having a high resolution anoscopy within 3 months, so we could assess many of our key outcomes. And those key outcomes of interest included co-infection of HPV at both the anal and cervical sites, concordance of HPV infections. So I mentioned HPV type 16 and 18 before, but whether or not we saw similar infections at both sites. And because we had data on multiple HPV DNA testing events for each of these women, we could also begin to assess the persistence of HPV infection as well as the clearance of infection. And together, we use that information to assess the potential contribution of persistence to the incidence of anal precancer. So this slide begins our results section. So on the left-hand side, there's a table describing some of the baseline characteristics of our cohort. So predominantly, this was a cohort of middle-aged women aged from their late 40s to late 50s. Many of the women had relatively high CD4 counts and relatively low viral load counts. So we think that this is most representative of an engaged in HIV care cohort. And many of the women had undergone multiple anal HPV screening events. And another way to think about this is multiple time points for intervention for potential screening and identification of precancer. And on the right-hand side, we have a chart showing the baseline prevalence of high-risk HPV by anatomic site. And you'll note that the most common presentation of high-risk HPV was at the anal site alone in just under half of participants. Just over a quarter of participants had co-infection, HPV at both anal and cervical sites, and only a small fraction had cervical HPV infection alone. On the left-hand side of this slide, we show a table that includes information about the baseline anal HPV type, as well as the concordance of that HPV type with the cervical site on the right-hand side. So in total, just under 40% of the cohort had either concordant infections at both sites or lacked infection at both sites, what we call a concordant negative. And the majority of people who had concordant HPV infection actually had concordant negative infection, so they lacked it at both the anal and cervical sites. In this cohort, inclusive of those who had anal HSIL at baseline and those who developed it over the course of the study, just under 1/3 of the study population of these women living with HIV had biopsy-proven anal precancer, anal HSIL. And among the 41 women who were living with HIV who had dual site infection at baseline, concordance of HPV types was 56%, and persistence of the anal HPV between the first and second screening events was just over half, with a median interval of about 1.5 years. And then finally, on this slide, we present some of the information about HSIL incidence. So in the table on the top, we present incidence of HSIL as measured by high resolution anoscopy or biopsy. And you'll note that the incidence among women living with HIV who had persistent infection was 22 per 100 person years, compared to about 3 per 100 person years among women who had cleared anal HPV. The table on the bottom shows some of the results of preliminary Poisson regression to account for the fact that we did have person time data and could assess rate of findings in this. As I mentioned before, comparing women who had persistent anal HPV infections to those who did not, the incidence was nearly 7 times greater. And then comparing women who had baseline HPV 16 or 18, the incidence was nearly 6 times greater compared to those who did not have that infection at baseline. And then interestingly enough, looking at cervical HPV infection at baseline, the incidence of HSIL among women who had cervical 16 or 18 was only about 1.5 times greater compared to those who did not have that baseline infection. So this was demonstrative of a weaker association in this particular cohort. So in summary, what we saw was that anal HPV infection was more common than cervical infection. We saw that high-risk HPV type was often not concordant between the two sites. And we saw that persistent anal HPV infection was actually appeared to be independent of cervical HPV status. and was also strongly associated with the development of anal precancer, those incident H cell lesions. So taken together, we feel that these findings challenge the theory that the cervix forms the main reservoir for HPV and provides some further evidence that anal cancer screening, including HPV testing, could be warranted for women living with HIV regardless of cervical HPV status, although prospective studies are still needed. So thank you to all of our study participants, as well as the Medical Student Research Office, and a special thanks to my research mentor, Dr. Siegel, as well as all of our other collaborators. And I'll leave you with these diagrams, which is for a prospective study that is recruiting now. And thank you for your time, and I'm happy to take any questions.
Great presentation, Kevin. Dr. Lin, do you have any questions? Oh, I think we have someone saying, great job, Kevin, you're amazing.
Thank you.
Go ahead.
Absolutely. So, Kevin, I'm just curious, given that this has been the case in HIV women, which are, it seems like more likely to have HPV, but we know that women without HIV also get HPV. What are your thoughts about anal cancer screening in women without HIV?
Yeah, that's a great question. I'm going to flip ahead a couple slides because I think I have some baseline information about that. So in terms of the epidemiology of anal cancer, we see the greatest risks in gay, bisexual, and other MSM who are living with HIV. The second highest risk group is women living with HIV. Then we see HIV negative, gay, bisexual, and other MSM. And then finally, the HIV negative women are that lowest risk cohort based on current data. I think there is an argument for screening everyone, particularly as long as we have an effective test that has high sensitivity that we know that the HPV testing is. I think as far as the data to support some of the quality metrics data, things like cost effectiveness, as well to determine whether it would be covered by insurance or recommended by the FDA. I think some of that data still is lacking. In particular, some of the HPV testing that's used now to identify anal precancer is still not currently recommended by the FDA. So that's certainly a barrier to really screening a larger cohort of women.
Excellent. I'm going to give just one more minute to see if Yakira, did you want to read that, or shall I read this next question?
I could read it. So given that you have multiple time points of testing for many of your participants, would you have any recommendations on how often anal cancer screening should be performed?
That's a great question. So as of right now, and I'll pull these up again, the screening guidelines from, in this case, the New York State Department of Health, but these are consistent with other guidelines from the Infectious Disease Society of America. These are meant to be annual conversations that clinicians are meant to be having with patients living with HIV. The anal cancer screening conversation is thus supposed to happen annually. Whether that happens or not, I'm not as privy to as other clinicians. But I think one of the things we're really interested in now is whether the HPV vaccination will have an effect on this in terms of determining who progresses to more invasive anal cancer screening. And like I said, we're still waiting on the FDA to approve some of these tests. But it's worth noting for this particular cohort, this was a group of older women who were not necessarily eligible for the HPV vaccine when it was first rolled out. But the FDA's current guidelines for HPV vaccination enable women in the age 27 to 45-year-old age group to engage in shared decision-making again with their clinician. And HIV is certainly one of the conditions that is considered as part of that shared decision-making. The concern about HPV vaccination is we know that it's effective in preventing anal cancer, vaginal cancer, and cancer at other sites. But we're not as aware of the fact that if someone is already has an HPV infection and gets vaccinated, whether that can prevent progression. I think some of there's some really interesting data that we're looking forward to over the next year, but that would be, again, one of the barriers in terms of how frequently should we be screening. And I think that's really dependent on the vaccination rollout.
Great. Kevin, thank you so much. It's really interesting work and exciting to hear about possible new applications. Thank you so much. And so our last speaker today is Mnami Tokuyama, who is speaking about SARS-CoV-2 infecting enterocytes in vivo and can persist up to 7 months following symptom resolution, work that she has done in the lab of Dr. Saurabh Mahandru. Mimi, can you share your, yeah, there you go. Mimi, are you on mute?
Oh, sorry. Okay, so thank you, Dr. Lin. As you just said, today I'm going to share some data about SARS-CoV-2 infection and persistence in intestinal tissues up to 7 months after resolution of acute illness, which is one of the projects I've been working on in Dr. Mahandru's lab over the last year. So COVID-19 is primarily a disease of the respiratory system with manifestations ranging from asymptomatic infection to severe life-threatening disease with end organ damage. Gastrointestinal symptoms represent the most common extrapulmonary manifestation of COVID-19, and viral RNA has been isolated from fecal samples of COVID-19 patients, which can persist longer than detection in nasopharyngeal swabs. Cell culture and organoid studies have demonstrated viral competence to infect intestinal tissue, but evidence of in vivo infection in humans is lacking. So investigation of potential GI involvement stems in part from high intestinal expression of ACE2, which is a host protein co-opted by the virus for cell entry. In these intestinal biopsies, ACE2 is in green, EpCAM, which is an epithelial marker, is in red, and then nuclei are in blue. Both the proximal small bowel and the distal small bowel demonstrate robust ACE2 protein by immunofluorescence with diminished expression in the colon. Other groups have also demonstrated ACE2 expression by many ileal epithelial cell subtypes via single cell sequencing. This group showed that 6.5% of epithelial cells co-express TMPRSS2, which is a serine protease capable of cleaving ACE2 to facilitate SARS-CoV-2 binding. So based on this data and infection models in human organoid cultures, we decided to analyze biopsy tissue from patients with current or previous COVID-19 for the presence of virus, focusing on the duodenum and the ileum. We recruited 29 patients undergoing clinically indicated endoscopic procedures with a history of COVID-19 confirmed by PCR testing or serological testing. Biopsies were analyzed via immunofluorescence and/or electron microscopy. The average age of these patients was 51.5 years, with a range from 7 to 90 years old, and 65.5% of these patients were male. The average number of days from last positive nasopharyngeal swab was 51 days, and the average number of days from symptom onset to procedure was 56.6 days. 7 of the 29 patients were PCR positive within 3 days of the procedure. Most of these patients had mild disease during their acute COVID-19 illness, 6 had severe disease, and 2 had moderate disease. 3 patients were asymptomatic and underwent testing due to a close contact exposure, 2 via PCR, and 1 several months after exposure by serology. 8 of these patients had COVID-attributed GI symptoms defined as greater than 1 episode of nausea, vomiting, or diarrhea at the time of admission for hospitalized patients. And then for outpatients, the same 3 GI symptoms were only considered attributable to COVID if documented during the visit where the COVID test was ordered. We initially included abdominal pain as a COVID-19 attributable GI symptom, but decided it was too nonspecific given the comorbidities in our cohort. Immunofluorescence for viral nucleocapsid was performed using rabbit antisera against recombinant nucleocapsid protein from SARS-CoV-1. Immunofluorescence was performed on biopsies from 25 of the 29 patients, of which 12 had detectable antigen in the duodenum, the ileum, or both. Nucleocapsid in these images is green, EpCAM, which again is an epithelial marker, is in red, and nuclei are in blue. Representative duodenal staining is at the top, and ileal staining is shown down here. Antigen, when present, was only detected in the epithelium and was patchy, but tended to be more diffuse in the ileum as compared to the duodenum. 10 small bowel biopsies from 10 patients undergoing endoscopic procedures prior to the pandemic were also stained as controls. Electron microscopy or tomography was also done in 14 patients, 7 of which had presumptive viral particles, as shown here. This inlet is a magnified version of this area here. Spike-like projections characteristic of coronaviruses are marked with the red dots. From this imaging, we noticed that the cells in which antigen or presumptive viral particles were identified appeared to have a goblet cell-like morphology. So we next sought to further define the epithelial subtypes with colocalizing viral products. This panel shows nucleocapsid again in green and MUC2 in red. MUC2 is an intestinal mucin produced by goblet cells. And then nuclei are again in blue. So there are scant nucleocapsid positive cells that are not positive for MUC2, shown by these arrows here, but the majority of them were MUC2 positive, shown here. Viral association with goblet cells was also seen by electron tomography. This panel shows a tomographic reconstruction of goblet cells in both the duodenum and in the ileum with presumptive virons within these membrane-bound compartments. And then here's our magnified images of the virons. To more definitively confirm that these viral particles are SARS-CoV-2, we've begun performing immuno-EM here. So this panel shows one of these presumptive viral particles denoted by this asterisk, and then spike protein are these dark black or brown dots surrounding. So despite detection of viral products, intestinal inflammation was mild or undetectable in most cases in our cohort. Only one patient had evidence of inflammation on endoscopy, and this was attributed to transplant rejection by pathology. 13 of the 29 patients had histologic signs of inflammation, such as scant neutrophils, shown here, or increased intraepithelial lymphocytes, shown here. 16 patients in the cohort had completely normal intestinal histology, shown here. Half of the patients with detectable viral products had histologically normal biopsies. There have been reports of so-called long COVID, a constellation of symptoms that persist in some patients after resolution of the acute infection. In our cohort, the average time from symptom onset to time of biopsy in the patients with detectable viral products was 47 days. Only 4 of these patients had GI symptoms associated with their acute COVID-19, and importantly, 4 patients where no viral products were detected had GI symptoms as well. One patient that had persistent GI symptoms returned for a repeat biopsy 7 months after resolution of his acute illness and continued to have viral antigen present on 2 consecutive biopsies. This patient continues to have symptoms of unexplained weight loss and abdominal pain. One of the major limitations of this study was small sample size. Additionally, this cohort of patients consists of hospitalized patients who tended to be closer to their acute illness and outpatients that tended to be further removed, both of which were scoped for clinically indicated reasons, so not specifically for research. We only have follow-up biopsies on 2 of these patients, so most of the biopsies are just 1 snapshot in time. And because positive staining is sparse, particularly in the duodenum, we may have false negatives due to inadequate biopsy sampling. So in summary, SARS-CoV-2 antigen and presumptive viral particles are present in small intestinal biopsies from COVID-19 patients. The majority of cells with detectable antigen in our cohort appear to be intestinal goblet cells, though this is an active area of investigation as the type of cell infected may be stage dependent. Despite the detection of viral products, inflammation is mild or undetectable in most cases. Detection of viral products did not correlate with GI symptoms in the acute setting in our cohort. Viral antigen can continue to be detected in intestinal tissue up to 7 months following symptom resolution. More work is needed to understand the mechanisms and long-term implications of infection and persistence in intestinal tissues. We've begun recruiting more patients, some of which are willing to be followed longitudinally so that we can start to address some of these things. I would like to thank all my lab mates in the Mahandru lab, the pathology and the gastroenterology departments, and all of the patients and participants at Mount Sinai Hospital. I'd also like to thank the Digestive Disease Research Foundation for funding my research time and the NIH for funding this study. Thank you for listening, and I'd be happy to take any questions.
Great presentation, Mnami. Any questions? Does anyone want to add a question to the Q&A?
Maybe that was an amazing presentation and such an amazing amount of work. I just had a really quick question with regards to, if you had any thoughts about the implications of this persistence of the viral particles in the GI tract and whether or not it could suggest that there could be long-term potential transmission through fecal materials, for example, even in patients who are no longer symptomatic.
So that's definitely a concern. One thing is that, so while RNA has been isolated from fecal samples, like a lot of different groups have done that, very few groups have been able to culture virus from fecal samples, like indicating that the inoculum is probably very low. And then additionally, just anecdotally from our cohort, one of the patients in our cohort who was persistently positive 3 months after his illness lives with 2 other people who to date have still not been infected. So that is definitely a concern and something that obviously we need to look into, but right now it doesn't seem like that's going to be an issue.
Okay, and there's a question in the Q&A that I'm going to read. So in regards to the patient that still has GI symptoms, what current treatment is this patient receiving?
So to my knowledge, the patient's just receiving like supportive treatment essentially, because I mean, it's not, so one, even though this patient has persistent symptoms and has, looks like he has viral virus still in his intestines, there are a lot of other patients, right, who have virus in their intestines who are not symptomatic. So even though he has persistent symptoms, it's sort of unclear whether the virus is causing that. So it makes sort of treatment decisions with respect to the virus hard in that regard.
Great, and there are a couple of comments in the Q&A. One person said that this is such a cool project, beautiful images. And someone else said that Mimi, you were my FlexMed interview host. The conversations I had with you and your suite mates were a huge reason why I wanted to attend Sinai. Thank you so much for your presentation.
Oh, that's so sweet.
Very nice. Yes. And no questions, no more questions.
Okay.
That was wonderful. And I get the honor of closing out Med Student Research Day. So really just want to thank everybody for their participation today, particularly the students and all of your hard work with doing research at a time that was particularly challenging for everybody, particularly to the mentors for your support, to Dean Charney, Dean Muller for your unwavering support of the Med Student Research Office and our students. I would be absolutely remiss if I did not thank everybody in the Med Student Research Office, and particularly a huge, huge shout out to Yakira and Grace, without whom this day would not have happened. The amount of work that needed to be done on the back end to make sure that the breakout rooms and the tech all moved along without too much of a hitch is really, really due to them and to Mary Rojas. So I really just want to make sure that we give some time to acknowledge that. And then finally, usually if this were in person, and hopefully next year we could do this in person, we usually at this time take a little bit of time to ask all the mentors in the room to stand up and just give everybody a big round of applause, because we know that we probably would not have been able to make it this far, any of us, without our mentors. So I just want to acknowledge them. And in the very, very end, acknowledge our students, in terms of anybody else in their lives who are here today, friends, family members who've supported our students along the way. We know that this is not always the easiest road, and we really, really appreciate all of your support for your students and for their careers and their lives going forward. So really thank you so much to everybody for all your effort and for making this day work. And we really hope that next year we'll be able to see you all in person. Take care, everybody. Have a good evening.